our webinar today on data and data dashboards. This came by popular demand. We have worked on having more and more data available to you, the public, and you working in coalitions, and we heard from people that they really wanted to talk to experts in data analytics and in public health, and we're really excited about the guest speakers that we have for you today. Christine Cristobal is going to be facilitating the meeting. She's our principal coach at California Healthcare Foundation and is working with many coalitions across the state to improve opioid safety. So Christine, please take it away.
Thank you, Kelly, and welcome everybody. Thanks so much for joining us. One of the most important ways that we know coalitions can bring people into the work and to the table is having a broad understanding of what data is available. And we know that all the coalitions actually are working very hard on thinking about what data they want to put in their dashboards. So we're excited to have this conversation today. So today we're going to get to have a deeper dive into the data. We'll talk about the 4 new spreadsheets that we now have available on actually 2 websites. One is the chcf.org website, and we'll be sharing that with you in the chat in just a few moments, and then also on the Epicenter CDPH website, and you'll get a chance to see that link and that website in action as well. So this data is now publicly available. It is difficult to get, and that's why we asked, and we're happy to have the partnership with Brandeis University and the Department of Public Health to package it for us. There are 4 different spreadsheets, as I mentioned. 2 are focused on ED and deaths data. One is county by county, and one shows all the counties together. And then the other spreadsheets focus on prescription data, both by county and by zip code. And so you'll get a chance to see more of that in just a moment. This is a 60-minute webinar, so I'm going to tightly facilitate this so that we have a chance to get to all of your questions, and we really entertain lots and lots of questions from you, from what you might think is a very basic or stupid question to really advanced questions, and we want to hear them all, and if we have more questions than we have time for, we'll reach out to folks afterwards. The way you can ask questions is to use the question box. So go ahead and type your questions in there, and then I'll collect those, and I'll help moderate the Q&A. So our 2 speakers today, we have Peter Kreiner from Brandeis University. He is a senior scientist there at the Institute for Behavioral Health at Brandeis, and also in their Prescription Drug Monitoring Program Center of Excellence, and he will be speaking first. And then after Peter, we have Steve Wirtz, and he is the Chief of Injury Surveillance and Epidemiology Section, Safe and Active Communities Branch at the California Department of Public Health, and we're both so grateful that you're spending your hour with us today. So without further ado, I will now hand it over to Peter.
Thanks, Christine, and thank you, Kelly, Christine, and Ravi for inviting me to participate in this webinar. I think it's really unusual for a state to present this sort of data via website, and particularly make it available to local community coalitions. So I'm excited to be a part of that. My role is to talk about the prescription data that we and the measures that we generated at Brandeis using Cures data that the California Cures Department provided to us. So I'm going to say a little bit about strengths and weaknesses of prescription monitoring program data. I'm going to quickly go over the measures that are available on the Healthcare Foundation website. And I'm going to give some examples, illustrative examples about how the data could be used to inform needs assessment and could be used to track trends over time at the local level. I should say, if you have any clarifying questions, if I say anything that's not clear or that you don't understand, feel free to type those questions in, and I'll try to address them while I'm talking. Otherwise, for discussion kind of questions, we'd ask that you hold those to the end. Thanks. So I'll say more about the cures data in particular, but in general, people are interested in prescription monitoring program data because they're available in a much more timely way than typical health outcome data, such as death certificate data, hospitalization data, emergency room visit data. Those data usually have a lag time of at least 1 year, often 2 years, whereas PDMP data tend to be available right away, even with de-identification and cleaning. They're usually available within a month. The data are prescription level data, meaning each record has information about a specific prescription that was issued, and included in that information is patient information, prescriber information, pharmacy information, as well as information about the particular drug prescribed, when the prescription was written, when it was filled, dosage, and strength of the drug. The data also contain location information on patient, prescriber, and pharmacy, so that particular individuals, particular sequences of events can be tracked in space and over time. The PDMP data also include method of payment. Typically, the categories are Medicaid, Medicare, private insurance, cash payment, and often a category for military or Veterans Administration payment. Some of the limitations, PDMP data in general do not include a unique identifier. There are a few exceptions. Kentucky requires Social Security number to be submitted, although that's not a panacea because it's not always submitted. But in general, PDMPs have patient name, birth date, street address, sometimes phone number, sometimes other information. And to determine which prescriptions belong to the same patient, they have to match the prescription records based on that patient identifying information. It's not a perfect science. The way Cures has done this in the past has been based on an exact match, so that if there happened to be a variation in the name, if there happened to be a typo, the prescription would get assigned to a different patient, even though incorrectly. Cures has recently undergone a major upgrade to Cures 2.0 that includes a much more sophisticated probabilistic matching procedures, so that prescriptions get assigned to the same patient based on a lot more intricate and hopefully accurate procedures. The PDMPs are recipients of data that pharmacies submit, so they're entirely reliant on the accuracy of the data that pharmacies put in. Usually there are filters on so that if important fields are missing or contain way out of bounds values, they get rejected. But there are errors that creep into the data nonetheless. And then different states have different sets of practices for monitoring data quality and trying to improve it. And there are certain particularities to how the data are recorded. For example, as needed prescriptions tend to get recorded by pharmacists based on the number of pills. So a 30-pill prescription with as needed might get recorded as a 30-day supply. The patient might use them in 10 days. The patient might use them in a year. Okay. So what data are available to you? You can see on the website, and so I'm not going to go over these in excruciating detail, but basically there are descriptive measures having to do with the number of opioid prescriptions per 1,000 residents per year. We've translated those opioid prescriptions into morphine milligram equivalents. So it's basically a measure of dosage that's consistent across opioid prescriptions. And we've converted the dosage measures into the equivalent number of 5 milligram Norco tablets per resident. There are some measures that are thought to confer protection. So the number of physicians who are waivered to carry out medically assisted treatment by prescribing buprenorphine. And California has matched a list of waivered physicians with their database so that we can see which of those waivered physicians are actively prescribing buprenorphine in a given year. There are a number of risk indicators. These have been drawn from the literature that has linked prescription histories with drug overdose and drug poisoning deaths, and in at least one case with insurance claims data. However, they're also based on expert opinion, and we're in the process of validating a number of these measures ourselves. So looking at high average daily dosage, the particular threshold tends to be a little bit arbitrary. One study suggested 100 morphine milligram equivalents a day over a 30-day period. It's associated with greatly heightened risk for dying of a drug overdose. CDC recent guidelines they talk about a 90 morphine milligram equivalents per day kind of threshold. One of the thresholds that California, the Cures, uses to generate electronic alerts to prescribers is having received average daily morphine dosage of more than 40 milligrams for at least a 30-day period. Also used as a trigger are the number are having received both opioid and benzodiazepine prescriptions during the same 30-day period. So our measure is the number of residents who receive those per 1,000 population. And finally, the number of people who per 1,000 who have obtained prescriptions from 6 or more prescribers or 6 or more pharmacies in a 6-month period. There's one more measure that didn't make it onto my slide that has to do with people who've received an opioid prescription for 90 days in a row. We've generated these measures from the Cures data that we've received, which is for 2010 through 2013 at both the county and zip code levels. County data are going to be a lot more reliable, and with the caveat that some counties have small populations, and so it may be advisable to aggregate across years. Zip code level is going to be tricky for very small population zip codes, so a number of caveats about using that data. Cures, as I mentioned, has upgraded to Cures 2.0. They're in the process of de-identifying their data, the Cures 2.0 data, and will be sending us an updated data set through 2015, either this month or next month, we hope. And when we receive those data, we will regenerate all of these measures. So, as I mentioned, they may include increased accuracy, and they'll certainly be more recent than these data. I'm going to provide some examples, what the data look like when they're mapped by county, how you might think about them and use them for needs assessment and tracking progress. So all of these maps have grouped the counties into quintiles, 20% groupings. And so you can see just looking at numbers of opioid prescriptions per 1,000 residents in 2013, it's not a random distribution geographically. The higher rates tend to cluster in some of the northern counties, which also have smaller populations. If we look at average dosage per resident, you can see it's a similar kind of clustering. It's not identical, but similar. And at the high end, These are people who are receiving 2,700 morphine milligram equivalents over a year. Tends to be relatively high, and that's averaged across a whole county. Now this is the percent, the number of let's see, this is the percent of people, so the title's a little bit off, who received an average of 100 morphine milligram equivalents per day for at least 30 days during 2013. And you can see again in some of the northern counties rates of upwards of 25, a quarter to a third, to even as high as 40% of patients. If we look at patients who have received both opioid and benzodiazepine prescriptions in the same month during 2013, again, it's getting a little repetitive to seeing the same kind of clustering, but there's a little bit of variation, and I wanted to highlight that by looking at changes in opioid prescribing rates. So this is this map. I should say the mean represents a decline of about 10% from 2010 to 2013, and these are measures of percentage change over that time, and the color gradations represent standard deviations from the mean. So the pink or towards red are counties that have experienced an increase in opioid prescribing rates relative to the mean, and the blue represent a decrease in relation to the mean. So we can see that while many of the northern counties had relatively high rates of opioid and benzodiazepine prescribing, they also tended to have a greater decrease in prescribing rates during the time period, with the potential exception of Trinity County, which I've got my arrow on here. If we look at changes in opioid dosage rates, somewhat different pattern, but again, Trinity County shows up as, in this case, sort of with an increase in rates relative to the mean. Mono County also shows up in the highest group for an increase, and a broader distribution of counties that experienced a decrease in average opioid dosage. I also looked at, in relation to changes in opioid prescribing rates and dosage, changes in the number of waivered physicians waivered to prescribe buprenorphine for medically assisted treatment. So again, it's of interest, the color coding here is such that the blue represents an increase in waivered physicians relative to the mean, and the red represents a decrease. So in the previous slide, the counties that might be of interest to think about allocating resources or for an intervention, Trinity, which was high on the various prescribing and dosage rates, and also where those rates seem to be increasing, also is a place where the number of waivered physicians tends to be decreasing relative to statewide. There was a slight increase in the number of physicians statewide, but not so much in Trinity County. So an example of how looking at cross-sectional variation in these measures by county and also looking at changes over time can be useful for highlighting the kind of needs that individual counties might have. Okay. So just sum up some observations, and I'm going to end there. If you have any questions, please type them in. If you think of questions after today's presentation, feel free to email them to me, and I'll try to answer them. Thanks.
Thank you so much, Peter. That's a great presentation. Do you think you could go back one slide and during Q&A we could take a look at the observations?
Oh, sure.
Great, wonderful. So a couple questions have come through already. One is, do all pharmacies have to submit data? I notice compounding pharmacies don't in California.
Yeah, states vary a little bit on that. All resident pharmacies do, and this is for outpatient prescriptions. States vary in terms of mail order pharmacies. Some states require them to, some states do not require them to. I'm not sure about California. Steve may know that, or otherwise it's a Mike Small question.
Yeah, I don't know that. This is Steve.
Yeah, thanks.
Okay. Another question was about the PowerPoint, whether the attendees are going to be emailed the PowerPoint presentation. And the answer is that within a week, the recording of this webinar as well as the PowerPoint will be posted on our website, the CHCF website. And in addition, if you would like the PowerPoint specifically emailed to you, I can give you Ravi's email address, which I'll put in the chat box in just a moment. The next question was, what does MME stand for?
Oh, sorry. Morphine milligram equivalents. So opioids, there are a lot of different molecules that represent opioid drugs. So OxyContin, morphine, buprenorphine. The people have worked out a way to convert the dosages in these different drugs to the so-called morphine milligram equivalent. So if the dosage were converted into this an equivalent strength of morphine, that's what it would represent. The Centers for Disease Control and Prevention provide a conversion table for different drugs into morphine milligram equivalents that we use to derive these MMEs. Some states, the prescription monitoring program, when physicians or pharmacists query the program on a patient, they will get the list of past prescriptions that patient has obtained. Some states are working out ways to also provide a summary of the morphine milligram equivalent total of their current prescriptions, which could be very useful.
Great. The next question is, would you mind sending out this information to those on the call so we can share with our counties? And there is another related question about whether we can distribute this now to others. And the first question, as I mentioned, this will be posted on the website, and I'll give you Ravi's email address if you want it sooner than within the week. My understanding is that this is now publicly available data and can be distributed to your networks or even to local media. Is that right, Peter? This can be now shared publicly.
Yes, it's so. Mike Small from Cures has provided this data to us. It's subject to the limitations of Cures process for deciding which prescriptions belong to the same patient, and we've provided the measures back to them. As far as I know, it's fine from our point of view. As far as I know, they've given permission to share it too. So, yeah.
Okay, great. And then just as a reminder, in the chat box, I copied and pasted the two websites where you can have links to the 4 spreadsheets that we're referring to. Okay, so next question is, the graphs focusing on change that you had were compared to the statewide mean. Is that correct?
Yes, where mean represents the mean of the counties. So it's not an average at the patient level, it's an average at the county level for the state. Does that make sense?
Okay, great. Okay, and then looks like oh no, I have a couple more, but here's a question. Is there access for the coalitions to get information about which Suboxone doctors that are actually prescribing using their X number. We did receive the list of doctors with X numbers in our area, but we are curious which ones are actually practicing and providing MAT treatment.
So when we've worked with Cures around having them match the list of waivered physicians with the Cures data, they've given us back the project-specific identifiers for those physicians, as well as what they're waivered for, 30 patients or 100 patients. So we don't know who the prescribers are. We know which county and even which zip code they're in. So the short answer is we can provide numbers of actively prescribing physicians in each area, but we can't provide names.
And Peter, can I jump in to add something there? This is Steve again. As part of our broader project, we do believe, working with the Healthcare Services, Department of Healthcare Services Pharmacy Branch, James Gasper, that we will be providing some further detail on that. I won't commit to anything, but I think we're going to have a way to try to help counties increase those numbers and increase the usage among those who are waivered.
Great.
And this is Kelly Piper. We do have all the names of each buprenorphine prescriber by county, but as has been mentioned, there's no way to actually link who is prescribing to a particular name due to privacy concerns.
Okay. Here's the next question. You mentioned there was higher prescribing rates in Northern California compared to the rest of the regions in California. When looking at the slide, California change in opioid prescribing rates 2010 to 2013, the standard deviation decreased. Would you be able to explain the reason of the decrease? Was there a policy introduced regarding opioid regulations that played a role, for example?
I don't have a good answer to that. Sometimes so-called reversion to the mean takes place. So in any distribution of values, the ones that are higher tend to decrease more, just as they move toward the mean over time. But I don't know enough about the particular policies that might have been put in place by counties in California.
And let me just say something again. Kelly, if you're not going to, what I was going to say is, as part of our project, we have a robust evaluation process that's going to be looking at policy as well as practice indicators, and we will try to address those kind of questions. I think there's some reason to think that there's more going on there with those northern counties than simply, the statistical regression to the means. But we're certainly not in a position to make any statements about that yet. But I think the Healthcare Foundation has been doing some work with Partnership Health Care System up there, and we may learn something from their activities.
Very good. Great.
Okay, great. Just a couple more questions and then we'll switch over to Steve. Let's see. This one is, does that mean that it will be skewed toward the larger counties?
The rates in many kind of measures, smaller population areas tend to have more variable rates and often higher rates just because it's a smaller population. So this is not, these are county level measures, and we're just comparing the rates directly from county to county without otherwise taking population into account. But in general, smaller population areas tend to have more extreme values.
Okay, and then this looks like the last couple of questions. So is the data collected by PDMP available to anyone or only by county DPH? I would love to take a look at our county's data, but our county substance use prevention programs are housed in behavioral health and not public health?
Well, I'm not sure what the questioner means by data. The prescription level data are not going to be available. But if the question has to do with, so the measures that I listed will be available at the county level on the Healthcare Foundation website. If other measures may be of interest, then we can think about generating those and maybe adding those to the list.
Okay. We know that not everyone in each county has been using cures, especially over this time period. Is there data on rates of cures used in each county? Is data adjusted for this?
In theory, that information, the cures would have that information about usage rates by providers across the state. We don't have it, and so the data that I presented is not adjusted for that, but that would be a great thing to look at.
Okay, and then last.
But can I clarify on that? All the fact that we don't have usage rate doesn't change who is reporting this distribution or dispensing of prescriptions, so that the numbers are not contingent upon the number of people going to cures to use it. Can you clarify that?
Right. Yeah. The pharmacies submit the data, and it has to do with filled prescriptions. It doesn't have anything to do with checking the PDMP. But if the question was more about do we have a way of looking at whether providers in different counties may have checked the PDMP more often, and maybe that was associated with decreasing prescribing rates over time. If that's the question, that's a good question, but we're not able to look at that right now.
And I'll add here, if Mike Small were on, and sometime we may want to have him come and talk more specifically, they are developing those kind of measures, and he would have more to say about when those would be available. But that kind of measure, for example, is very important to our evaluation of the overall intervention. So that will be being tracked. It's just maybe not available to you at this point.
Mm-hmm. Good.
Okay, and then I'll read. There's a comment here positing an idea about why there was the decrease during prescribing in this time period. During that time period, there has been a general concern about the overuse and overprescribing of opioids, which may have led to the decrease.
Mm-hmm.
So, okay.
Could well be. The question which Steve is trying to address was, would there be differences in that concern by county in California?
Great. Okay. Well, thank you very much, Peter. Obviously, a lot of interest and a lot of great questions were stimulated from your presentation. So thank you so much. And I hope that you're able to hang on with us, because we'll have more time for Q&A at the end.
Sure.
As well. So now we'll shift to Steve Wirtz from CDPH. And so we've heard now about 2 out of the 4 new spreadsheets of data that are available on 2 separate websites, the prescription data. And now we'll get to take a little deeper dive into the other 2 spreadsheets that are looking at ED and deaths data. So take it away, Steve.
What I'm going to try to do very quickly is go through what we're trying to do as partners here at the Department of Public Health. We have a team now of data people. Kathy Psyche and John Puglisi are also on my team. And what we wanted just to say is that all of this data really serves the broader purpose of building a comprehensive approach and leveraging multi-sector collaboration at state and local levels. So this is part of that larger context around safe prescribing, access to treatment, naloxone distribution. I wanted to then just let you know that there is a full range of data sources that might be relevant to you in some context, and we're only going to be talking today about the 2 that here. You've already heard from Peter about prescribing and dispensing data from cures, and I'm going to be talking about the health data as consequence data. There are 3 basic data sources that we're focusing on around health consequences. There are many others, but we're just focusing today on deaths, hospitalizations and emergency department data. And the death data comes from our department, California Department of Public Health, in their vital statistics area. But the hospital and ED data comes from the Office of Statewide Health Planning and Development. And at times they have even more timely data. So what we try to do with the data is make it more available and usable to our potential users. So I'm going to talk about 3 ways that we now have to approach this data. The first exciting way is with regard to the data that's now on the CHCF website. And that has 4 indicators, again, for generally the same time period, 2011 through 13 for deaths and 2011 through 14 for the ED visits. And we're looking at just for now 4 indicators. Obviously we can develop, we have other ones as well, but overall drug deaths, and that's for all types of drug overdose, poisoning deaths, and so that's just a very generic high-level measure. And then we have on the spreadsheets I'm going to show you in a second, we have prescription opioid deaths, as well as heroin, which are relatively small number by counties, and then the non-fatal opioid-related ED visits. Now I'm going to do this several times during the talk. Hopefully it will go well. I'm switching to go over to the website for the California Healthcare Foundation, and this is the website upon which you can go. The website has been it's been shown to you. You can go here to the opioid safety data and download the following sets of indicator data that you see here. The sum that Peter already talked about, and here's the 4 measures that we're talking about here. What you would see when you do that is this kind of a Excel chart, and it's going to start with some instructions about what the indicators are, something about what the various sheets are here, and a little bit about the background for the definition of the data. So if we just look at this one very quickly, this gives you all counties along here, all the counties and a California total here, which gives you some baseline to do the comparisons of your county. I've highlighted Humboldt just because it's one of the Northern California counties that has some of the higher rates, not picking on them by any means, but you'll see that we have the overall drug deaths and a rate for those, and rates are often helpful. I'll show you how using rates are a way to sort of control for the population, so that smaller counties are going to have smaller numbers, and there's going to be more variation year to year for them, but the rate, if it's big enough, is stable enough to show you a comparison. And then we have the prescription opioid death numbers here and a rate for those. And again, you can see that Humboldt's rate is higher than some, but not as high as Del Norte and Inyo, and Lake is one of our highest, and down here Plumas is also one of the high ones. So this gives you a simple way of looking at those. And then the opioid-related ED visits is a good one to look at because it gives you some big numbers and therefore more stability in your rates. Again, you can see Humboldt has a fairly high rate compared to many of these other counties. This way, where we provide all of the indicators for each of the years across the top, and you can read more more instructions around that when you go and download that data. The one unique thing about this data, because we haven't been able to get our web-based program up to speed, the prescription opioid deaths are only available on those spreadsheets you just saw. We don't have those available on the Epicenter queries, the Epicenter query system here that I'm going to show you next. So on the Epicenter, we've developed this a while back for injury, and all of the prescription issues fall under poisoning, so they're an injury for us. So there are some limitations of our Epicenter because it was designed not specifically to address this epidemic that we're having. So I'll point those out that as I show you this. First, it has some strengths. It's quick and easy to use, we think. It's available 24/7 generally. It's been down very few times. It provides county level data. It doesn't provide zip code, but and you can create your own custom tables. That's what we think is really the most powerful part of it. We try to use the CDC standards on how to identify the various substances, and we allow for downloading of that data for your own analyses. However, it's not timely. We are dependent upon our ability to access these other existing data sets. And for example, we're also dependent on our work with our IT folks to get the data up. So right now, for our death, we've been having problems. We're only 2013, but soon should have that fixed. We're also limited primarily in this health data to the coding systems that exist across the world. They're called the ICD codes, and they're not very specific for some of our drugs. So that's a problem, and we've also just said we don't have below county level data. So this is what the epicenter looks like, and again, I'm going to switch to bring that up live to give you a sense. Across the top are these tabs. The alcohol and drug consequences area is a separate tab, and it looks like this. I'm going to show you in just a second an outcome from this. So you can choose the various levels: deaths, non-fatal hospitals, and non-fatal EDs. You can pick a variety of years. You can pick crude rates, and as it shows here, you can pick all counties or any individual or any grouping of counties by race, ethnicity, and by age group. And then you choose, in this case, each of these selections is based on the data system, the ICD codes that are available. So this is non-fatal emergency department data, so you can see you can get all other drugs, or you can get these by specific drug categories. But for this data, you can have limited data on breaking down the opioids. So we're taking the opioids. We're taking the most. There are ways of looking at the data as the principal cause for why they were brought to why they were treated at the hospital, or any mention of this. And each of those we can talk about later have a different sort of strengths and weaknesses. For the consequences, we're focusing on the poisonings, but you can see you can also look at all consequences, and you get some different numbers when you look at the mental disorder coding for hospitalizations as well. Then you can also then choose. Up here we've chosen several years. So down here you pick that you want to sort it by years. You can pick other sorts. And then I'm just going to show you what comes up. If you did this run here, you get this output. It shows you the years, all ages, all races. For this happens to be, I did it for all of California rather than any specific county. It's for opioids, poisonings, and it gives you, the reason I chose this is that the ED data is really powerful in showing the trends of what's been happening. If you look at the numbers, they're increasing, but if you look at the rates, they're also increasing. You could see almost whatever it is, an 80% increase in rates and numbers since 2006. So this allows you to do this for any particular county. I'm not going to do it by county right now because I'm not certain how many seconds it will be before the results come out. But generally, you can pick a county, or look at this in more details by your age groups or whatever. So coming back to our slides, I'm going to just now show you a couple examples. So this is what we just did. And here's another outcome looking at deaths. Again, for the state, I wanted to point out that on our website now, these two, methadones and other opioid pharmaceuticals, really are what are the codes that are available, and what we call prescription drugs would be the combination of these two categories. However, right here, these numbers may have some duplication. So that's what we're saying that we don't have on this website, the prescription drug indicator that you do have on the CHCF website. Just going on to give you another sense, this is just a way to take that data, and we said here you had to have at least 20 cases to be on here. Humboldt happens. There are other small counties that have high rates as well. These are just examples of what you could do with this. So I'm skipping over this one to show you now. This is non-fatal emergency department visits, summarizing the 4 years of data here, 5 years of data for opioid poisonings. This is a way that we used in part to determine our priorities for our grant. And I've circled Del Norte and Humboldt as they have some of the highest rates. This next slide circles all the other counties that have the highest rates, above 31, I think it is, or Lake, Mendocino, Plumas, Santa Clara, Shasta, Sutter, Tehama, Tuolumne. And you'll notice that, one, there are a lot of the Northern California counties that Peter pointed out, and they're also the basis for California Healthcare Foundation's partial selection of high-need counties. Here's another way. That was 5-year total data. Here's what happens when you use 1 year. There's slight, because of the small numbers relatively, there's slight change in who's in the top, but nonetheless, you'll see that Humboldt, is still up there, and some of these don't have enough numbers in to be up here, like Plumas probably drops out on a single year. That's why we combine years. I just want to give you another sense that something we've done. We can look at multiple drug categories. So here's all opioids have increased from 2010 to 14 by 44%, but heroin has almost twice that increase. So you get that sense. These data are just created by running a couple query tables and putting them together. Amphetamines are also high, going up. So it just gives you a sense of how you can use this site. And then I want to go to our third level, that with our new staff and with the funding from this project, we're moving toward having a Epicenter version 2.0 that can start looking at this in a more user-friendly way, that you could choose, in this case, a map that shows you the one indicator we had, the overall drug overdose deaths, just one example of what this is going to look like. You could also then take a particular county and look across years and get a bar chart, and again, just using this one example. Or you can translate that into just looking at the years in a table format and get the raw numbers. So we're just beginning to develop this prototype, and we'll be working on that over the next several months and longer to get it up and running. But we wanted to just show you that potential for data options here. So I'm hoping that gives you a place to get some of this data immediately. If you are having trouble with any of the two sources that are available now, the CHCF website or with our Epicenter website, you can certainly let us know. We often do online consultations. And with that, I'll end and see if you have questions for Peter or myself.
Great. Thank you so much, Steve. The Epicenter tool is very powerful, the interactive nature of it. I'm sure all the coalitions are going to get a lot of use out of that. There are a few questions. One question is, when does the data get updated from 2013 to 2014?
And that's a good question. 2014 is available. We just have not been able to get our system up in place to do that. We expect it within a month to have the death data up there, hopefully sooner than that, but within a month is a reasonable expectation. Okay. And we're also going to be working with the vital statistics folks and OSHPAD to look at other avenues potentially to see if there are ways to get even more timely data. I know OSHPAD has the potential of doing that. We want to make sure that data is available wherever it's available accurately and timely. So we'll work on trying to improve the timeliness of the data as we go along.
Great. Okay, so a clarification question here. So hi, Steve. Did you say the spreadsheets, oops, hold on one second. Did you say the spreadsheets on the CHCF website will have unduplicated data, while the Epicenter may have overlapping data when broken out by opioid type?
Yes. If on the Epicenter, if you do opioids all opioids, you will get the right answer. And so if I were wanting to, and then we have 4 codes for breaking down opioids that you saw: methadone, other pharmaceuticals, heroin, other illegals. If you added those 4 separate groups together, you would have a larger number than when you do all opioids separate. So if you want to see how that works, you start with saying how many opioids were there total, and then you do your breakdowns, and then you will see that, oh geez, there's 35 more cases when I add up the 4 than there are for the all opioids. So yes, for the individual codes, because we use multiple cause of death files, you will have the possibility of having the coroner and the system having identified heroin and OxyContin potentially.
Got it. Okay. Is it possible to say which variable is used for the county? For example, when the variable in the table says county, is this based on the patient county zip code, and is the data cleaned prior to running the queries? OSHPA data has some variables that have incorrect data input into the data fields.
We trust, we get our data from OSHPA, and we test it, and if we find what we think are problems, we communicate with our partners and address it that way. But in general, we take OSHPA data as the starting point for us. But to clarify then, when we talk about county, we are talking about residents in the county. So a person that comes in and dies of an opioid overdose in Plumas, but they came from San Francisco or Sacramento, that would be quoted from our purposes as a Sacramento or San Francisco case. So we use residents as the way to sort cases.
Okay. Were the rates in Steve's presentation crude rates or age adjusted? If not age adjusted, can he explain why it wasn't age adjusted?
We do both. On Epicenter, it's a bit hard for us to program that, so they are crude rates and they're specified as such. Age-adjusted rates obviously take into account that different counties have a different variation in the age groupings. There may be more older people in the rural areas, and that may, we know that that might affect the number of opioid overdoses. So they are crude rates, not age adjusted. So age adjusted are more appropriate, and we're working toward getting the technology to do that on our displays. However, I would say that there seldom are the differences profoundly substantial. It's more accurate, and there could be some clarifications you would miss without them, and we're working on moving in that direction.
Okay. Could you talk about any mention versus principal cause of admission for ED visits, when each should be used?
Very good question, and I'm not going to have a sure answer. They each have a different meaning and a different potential interpretation. On the simple level, I would argue that the principal diagnosis is the diagnosis that the physician wrote as the primary reason for the admission. And so therefore it's a very precise statement saying this was clearly an opioid admission. The reason for this admission was primarily due to the opioid. And therefore it's also more restricted. Let's say someone was, the good example is alcohol, but it could be drug-impaired driving as well. They come in with a motor vehicle crash and they have all kinds of injuries. That's what would be coded as the principal reason for the physician dealing with them, and you would lose the fact that they were drug-impaired. The any mention variable, on the other hand, would capture that potentially, and it would just not be the principal diagnosis. So I would say the principal diagnosis is more narrowly focused and is more accurately. So what is it? It's more specific, but specificity and sensitivity. It's more sensitive but less specific than any mention. So I tend to think it's useful to look at both of those. The any mention could be too broad, even though it still doesn't capture the motor vehicle kinds of cases necessarily. So they both have their purpose. I think the most conservative and CDC tends to focus on the principal diagnoses. The other gives you a good picture, though, of how widespread your problem might actually be.
All right, a few more questions. Is that true? Oh, sorry, this is going back to the overlapping data question that was asked earlier. The follow-up is that true for hospital ER files as well?
We choose a principal diagnosis and or a principal E-code. So there is a case where you might have a different drug is called the diagnosis and the other is the E-code. Very few of those. So for principal code, yes, there's a slight, very slight overlap. I would not worry about it for general purposes. When you use any mention, of course, then you have the duplication.
We have 3 large prisons in our county. Is this data excluding the incarcerated as they are included in our general population counts regularly?
Good question. I think I want to hold off. I think they are not because I'm not sure. I'd rather not answer that and find out the right answer. I have a couple answers, but one of them is wrong, I know. So good question. I'll hold off and get back to you.
Okay, perfect. Okay, and then here's a note for everyone that somebody put in there. Age-adjusted death rates can be obtained from the CDC Wonder website.
That's true, and I think in one of my slides I pointed out that you could either use Wonder or CDC Whiskers to look at poisoning data for California, and there are reasons why there are slight differences between California data and CDC due to timing, and we think we're using basically the same codes, but timing of the process. So if there's slight differences, it's usually because of the methodology of getting the data finalized to each agency, to the state agency and to the federal agency.
Okay, and then how do you obtain the data in a table by year?
On Epicenter, let me just go back to Epicenter and just show you very quick if we have the time. All you do by age group would be go down to the very bottom, additional details, and you've got single age 5-year groups. So let's do a 5-year group age and drop. We're going to add, we're doing all of the state. Let's see how quickly it comes up. But you just choose the age variable. So there you go.
Fantastic. Okay.
Yeah, you can see that the rates are, that actually increasing in the 20 to 30 range and have remained high in the 45 to 59 or so. So just to give you a sense there for opioid poisonings.
Great. Well, unfortunately, we'll have to end the webinar. And if we weren't able to answer your questions, we'll comb through the questions again, and we'll make sure that we address them after the webinar. You will all get a link to the website with the recording, and the PowerPoint will be on the website within the week. And I just want to thank again Peter and Steve for your excellent presentations. Clearly this is really central to the planning and bringing stakeholders to the table for all the coalitions, and it's very exciting to have this available. So thank you very much. And then thanks to everybody who joined us today for your time, and we look forward to your continued questions and conversations through this work. Have a good day, everyone.